Okay, welcome back everyone to our next session here at the Patient Engagement Virtual Day. Our second panel discussion of the day, Trend Watch Digital Health Prescribing. If you have any questions for our panelists during this session here today, please utilize the chat functionality within the Zoom platform. With that said, I would love to, at this time, introduce our senior editor here at Healthcare Innovation, David Ratz, who will be our moderator for this panel discussion. David, the virtual floor is yours.
Thank you, Matt. I think this is going to be an interesting discussion. Increasingly, health systems are making it easier for clinicians to prescribe and track usage of digital therapeutics and apps. And popular offerings range from shared decision-making tools and questionnaires for surgical prep and post-operative recovery apps, and behavioral health apps, and diabetes management. So we have three digital health leaders with us today to talk about their efforts to standardize and track digital health prescribing across their ecosystems. With us are Jeff Johnson, Vice President of Innovation and Digital Business at Banner Health; Sarah Vasey, Chief Digital Strategy Officer for Providence St. Joseph Health; and Dr. Mark Zhang, Medical Director for the Brigham Digital Innovation Hub at Brigham and Women's Hospital. So before we dive into some detailed topics, let's go around and just have everybody describe their organization and their own role in digital health innovation there. Sarah, could you go first?
Sure, and thank you for having me today. As you noted, I'm Sarah Vasey. I'm the head of digital strategy at Providence. Providence is a large integrated delivery network in the Western United States. We span, our presence spans from Alaska through Texas and New Mexico and many states in between. The largest markets that we have are Seattle and Southern California. So we are quite, quite expansive in the breadth and depth of our network. Actually, we are vertically integrated, so we have a health plan. We actually operate a high school and a university. So Providence really is quite expansive in its thinking as it relates to health, as well as healthcare and health delivery across the United States. I sit within the Digital Innovation Group, which is a group of approximately 200 folks who span marketing, ventures, digital innovation, digital strategy, product development, and investment. And we are really focused on digitally transforming the consumer and patient-facing front end of the organization. So thinking about everything from discovery through delivery and engagement, and digitally enabling it using both technology that we develop as well as partnerships with technology companies outside of Providence.
Okay, great. Mark, do you want to talk about your role at Brigham?
Of course. Hi, everyone. It's a pleasure to be on this panel. I'm Mark Zhang. I'm the Medical Director for the Digital Innovation Hub at Brigham and Women's Hospital. I'm also a palliative care physician at Dana-Farber and Brigham and Women's, and a clinical informatician at BWH. Brigham is one of the academic medical centers that anchor Mass General Brigham, which is a large integrated healthcare system, the largest in Massachusetts. The other academic medical center is Mass General. We're both quaternary care hospitals that are part of affiliated with Harvard Medical School, and we also have a large community outreach as well, with multiple community hospitals and a insurance arm as well, and other care facilities. The iHub sits within Brigham IS. We're essentially the Center for Digital Health at Brigham and Women's, and we function in four ways. We help kind of the community within Brigham who have ideas in digital health kind of move their ideas forward. We host events. We also help individuals get their ideas from back of the napkin to hopefully to a product. And we've actually helped spin out a couple companies since our conception in 2013. During COVID, we worked at the system level to really implement a lot of digital solutions for the entire organization, and have championed many different products that we think will help move kind of the digital needle forward, including the topic for today, digital prescribing. So okay. Pleasure being here.
Great. And Jeff, how about your role at Banner?
Yeah, first of all, thank you for having me. Pleasure to be here as well. Yeah, my role is Vice President of Digital Business and Innovation at Banner Health. Banner is a not-for-profit integrated delivery network. We're based in Phoenix, Arizona. We operate 30 hospitals across 6 states, as well as hundreds of clinics and ambulatory services. We provide everything from urgent care to quaternary care through our community and academic hospitals at the University of Arizona. And we pretty much do everything in between. We've got standalone imaging centers, ASCs, physical therapy, home care, retail pharmacy, specialty pharmacy. So we really have a breadth of healthcare services on our platform to bring to our community and our market. Additionally, like Providence, we have our own insurance arm. We do that through a joint venture with Aetna, and we have approximately 55,000 employees. Our mission is to make healthcare easier so life can be better. My role as Vice President of Digital Business is within our growth and strategy team. That's really the lens that we look at digital with first and foremost, is as a growth and a strategic opportunity for us. And I really focus on leading an enterprise-wide strategy across this plethora of services that I mentioned, so that we really are presenting ourselves to the customer around her foremost, rather than around our service lines or our different functional areas. And so that's really my role in the organization. We really tackle that kind of digital strategy on 3 main fronts: what we call the digital consumer, the digitally engaged patient, and the digital workforce. And that's just our way of trying to rationalize the sheer amount of work to be done in the space. But that's the way we've set ourselves up to go forward.
Okay, great. Well, thank you all for giving that. That's really great to have that background. So my first question is for Sarah. Maybe we could start by defining what a digital health formulary is, because this is all rather new, and maybe also give a little bit of background about the platform company Xelft, which a lot of the big players in healthcare are using now. It was incubated at Providence, right? So maybe you could talk a little bit about that.
Absolutely. And, I'll start with kind of providing a bit of context, which many of the folks on this that are listening today may be familiar with. There are hundreds of thousands of digital health applications out there. There are other products and services that can be prescribed digitally, even if they are offline, like physical things. And so a digital health formulary, in my mind, is really what provides that sort of curated library or menu of services, products, apps, etc., that can be prescribed digitally. And what's more important, though, is not just that they're there and that they can be made available, but that there is sort of this connection to the provider and the patient that is digitally enabled. And that's where Xelft comes in. So when the entrepreneurial team that was led by Mike McSherry, that is currently led by Mike McSherry, joined Providence many years ago, I think back actually in 2015, they had joined, they identified a problem, and just actually maybe I should say more of an opportunity, which is that anytime one of our patients goes in to see one of our physicians, and they may need some sort of follow-up digital app, for instance. Let's use the example of a diabetes prevention program. At the time, the Xelft team recognized that what happens in that scenario is that the patient is handed a piece of paper and said, you should really go download this app. Let's say it's Omada for diabetes prevention. Okay, so what does that actually do? It doesn't necessarily provide, it creates a bit of friction for the patient to go and download the app themselves, go find it, go determine whether their payer is going to pay for it. And it doesn't create a feedback loop to the provider, whether the patient actually did it and whether they're engaging with it. And so there is all these points of just sort of fragmentation and not really taking advantage of that opportunity between the patient and the provider, what we call at Providence as the sacred encounter, to foster engagement on an ongoing basis between episodes of care. And so the Xelft team recognized this and said, wouldn't it be great if we could provide a platform for prescribing apps, products, and services that does foster that capitalizes on that engagement opportunity each and every time. And so that's what Zelf is. Zelf is, the prescription platform for that. And over time, as it relates to the formulary, it can connect Providence and our providers and our patients to the vast ecosystem of third-party applications and products and services that are available out there without forcing us as the system to kind of try to out innovate the market, if you will. There's sort of this notion of just tapping into the innovation that's already out there and making it available, as opposed to trying to recreate it or keep up with it. And so those are some of the things that, when I think about digital formulary and the problem that Zelf solved for us, that come to mind. And of course, there are many constituencies, as I described. It's the health system itself, it's the provider, it's the patient, it's the digital team that really has this vested interest in creating increased engagement from a digital standpoint. And so all of these are sort of facilitated through that notion.
Okay. Jeff, let me turn to you. I understand Banner Health had a successful launch of using an app called Baby Scripts. Can you describe first briefly what that app does? Talk about how it was piloted within the health systems and then its wider rollout.
Sure. So Baby Scripts, for those not familiar, is an app that's really designed for expectant mothers to help guide them through their pregnancy. And it does a couple of things, at least in the instance that we piloted. First, it provides content that's really specific to their point of gestation. So where they are in their pregnancy, it's giving them really relevant, personalized content. And then the other component that it does is it has an integrated blood pressure cuff, so that we can be collecting blood pressure readings for these otherwise healthy pregnancies to make sure that they're staying on track. And the opportunity there is that by getting this kind of connection with the expectant mother during her pregnancy, we can actually reduce some of the times that she may need to physically come into a clinic, because we're keeping such good connection with her and we're having these blood pressure readings. So we ran that pilot up in one of our northern Colorado clinics, and it was just a phenomenal success. First of all, the mothers loved it. And we picked our mothers because they're a key audience for us. They're oftentimes the ones that are driving the healthcare decisions in a family, both clinically and financially. They're also, they're digital natives. They're fairly a young population. So it was a really important demographic for us to connect with. But they loved it. And we did that pilot during the pandemic year. That pandemic heightened the value of it. We had, mothers that didn't want to necessarily come into a clinic for nothing but a blood pressure reading, dragging 3 other toddlers with them and potentially exposing them in a clinic. And so that value is heightened. Additionally, that was somewhat of a rural area for us too. So you can imagine mothers coming down from Southeast Wyoming in the winter just to come in for a 5-minute blood pressure check, and then we send them back on the freeway again. So it worked out really well. Our physicians were also very excited about it. In fact, when we moved it out of pilot, we were going to wait and to scale it across the organization until when we had Zelf implemented, thinking, well, our physicians will really want to have this, in the fully integrated workflow approach, rather than doing kind of the manual pilot things that we did in Northern Colorado. But they surprised us and they said, no, we want to get our hands on this so fast, we're not waiting for Zelf. We're going to do this manually. So we've now rolled it out across both of our medical groups, our academic medical group and our other medical group. And we do, in fact, have it integrated into Zelf now. But it was just very, very well received from both our clinicians as well as our customers.
And are there some other chronic conditions or use cases that Banner wants to go after next?
Yeah, we're just about to pull the trigger on a contract with a behavioral health solution. Hopefully I'll be able to announce that any day now. I wish I could have done it today. And then that's a key area for us. We're also looking at some things in heart failure, substance abuse, and of course, diabetes, which is a big issue. So probably the usual suspects for most organizations, but it's really starting to bubble up and we're getting more and more enthusiasm about this type of care delivery.
Great. Mark, can you talk about your experience with digital app prescribing at Brigham? I think you mentioned to me that you started with a pilot of WellDoc. Is that right? Can you talk about what that does and your experience?
Of course. So, I think as Sarah kind of mentioned earlier on, one of the big pain points that we see is that, as we move towards more and more of the public and our patient population, really becomes more savvy with digital products and mobile and digital solutions, our healthcare systems, and particularly at Mass General Brigham, we're slowly kind of getting to speed. And prior to kind of the advent of a digital prescribing solution like Xealth, we would really be doing it one-off based on kind of the individual physician's practice or a clinician's practice without many integrations, and that leads to a lot of pain points such as different portals for different solutions, and then there's compliance on both ends, whether it's a patient or the clinician actually following up to see if things are done. So when we actually were evaluating kind of solutions to help bridge this, certainly Xealth was a clear front runner, and one of the projects that we actually piloted it on was this application that WellDoc actually created. They have a chronic care management platform that's mobile first, very, very nice. And as part of that, one of their modules is a diabetes module. And as we were evaluating kind of digital prescribing as a solution, we wanted to actually look at use cases where the clinical solution was not actually what we were evaluating. More so, we wanted to look at something that was already in use, but had kind of turbulence with the actual prescribing component. So this was a perfect example with WellDoc, where actually one of the clinics, the ambulatory practice of the future at Mass General, they were already using WellDoc, and it was actually a pretty successful but limited pilot. And the main pain point was the whole thing to onboard a patient to their pilot was incredibly manual, and it was very painful, a lot of steps. And we thought this would be a great opportunity to actually utilize Xealth to, one, see if that would help with both the onboarding, but also see if the experience, given that it's more integrated, would actually set the experience apart. Unfortunately, around the time we started this, COVID happened, so that was a big roadblock. But we've fortunately gone through it, and I can say that since we've implemented the Xealth solution, we've seen considerable anecdotal positive feedback from both clinicians and patients, saying that it's much easier as a flow, and importantly for clinicians, being able to see kind of usage and track right in REHR has been incredibly helpful.
So here's one I want to address to all three of you, but I'll start with you, Mark. So is change management and governance, making decisions about this, one of the biggest challenges to overcome? Is it kind of and how have you addressed that?
Yeah, I think absolutely with any kind of large scale kind of fundamentally paradigm shifting thing like digital prescribing, I think change management is a huge thing that you have to address. And frankly, we spent a lot of time at the beginning of this, just getting the right stakeholders on board, and really being very thoughtful and picky about finding the appropriate pilots. We spent a considerable amount of time finding the right pilots to actually evaluate Xealth on, because again, it's so easy in these situations to conflate the benefit of the actual application with the prescribing tool. And let's say you just picked the wrong app for whatever the reason, you don't want to throw the proverbial baby with the bathwater, right? So being very choosy about that has been incredibly important, and frankly also just getting the buy-in and the time to do the implementation correctly. Just the underlying infrastructure was a very rewarding, but also a very time-intensive effort. But I think our hope, and what we're at least seeing now, is that hopefully this investment will pay off. As now that it's all the infrastructure is there, we'll be able to leverage it more and more. But to answer your original question, I think change management is incredibly important for something like this.
Sarah, let me throw that to you. That change management and governance aspect, what were some experiences in Providence around that?
Yeah, absolutely. And I think very similar to what Mark just described. And you know, I think fundamentally this is a governance and Mark, your light went off. It's fundamentally a governance and change management issue, and a workflow one as well. I would add to that, which is so they're not necessarily, like, strictly speaking, technology challenges. One of the things that we've done is that to address Mark's point, like, what is it that you even pilot and test, right? Is we've spent quite a bit of time from a digital perspective getting really clear on our strategy, and what that means is what problem are we trying to solve, and then we go through a really systematic approach to evaluating technology in the context of that problem. And then we can use Zelf or other mechanisms to other platforms to make those things available to our providers and our patients. But deciding what to do and why we're going to do it and what's the business case associated with it has been a real like the focus and the real difficulty, I would say. And frankly, then once you do that, like, what are the systems and structures in place to make that decision on an ongoing basis in a scalable way, as opposed to like on a one-off every single time you got to redo the whole thing, right? And so that's been that definitely is an ongoing challenge for us. And the other issue, just speaking of like business case, that's been really interesting for us is I think Jeff referenced behavioral health, right? There's always these questions around how do you determine, in the context of your strategy, when there isn't an ostensible business case for you, like how do you partner, for instance, with payers to make this a viable strategy and an approach. And so, and I think you have some questions that we'll get to that in a bit, but I think, so it's part change management, part governance, part strategy, and part like, how do you actually restructure the payment and the partnerships to facilitate sort of enabling this based on where value accrues. And so I think those are like four of the main pillars that we've had to work through in terms of actually enabling digital formularies and making that third-party ecosystem available to folks. So and I know we'll get into some of the details, so I'll just stop there.
Okay. Jeff, do you want to weigh in on that? It seems to me like all of you work in pretty big health systems, so getting that spread across and large geographically too. And so getting that spread across all those provider organizations must be pretty challenging, and making decisions across those. Jeff, do you have any comment on those?
Well, I agree with Mark and Sarah. I don't want to repeat what they said, but yeah, that's just what I wake up and do every day, is try to say, how is a whole entire organization, how do we align ourselves around the customer so that isn't just 1,000 points of light, but it's like this one spotlight on the customer, because there's lots of initiatives. Sometimes we're initiating those from our own research. Sometimes we're just wrangling them in and partnering with different groups to sort of bring them into the fold and enable them in a more scalable way. And so, we've talked a lot about Zelf, which is a really powerful enabling technology, but we really see as part of a companion to that is a governance model around digital therapeutics. Because there's a lot of stakeholders as we've found. Oftentimes these apps have patient education in them. Well, how do you make sure that that education is consistent with a printout that they may get in a clinic, and that you're not inadvertently giving your patient two disparate sets of instructions about how to manage their condition? It touches devices that our IT team and our telehealth team are also looking at. And how do we make sure that we're not pushing duplicate devices out to our customer for those kinds of things? And then our medical informatics group and IT teams, and obviously our clinical teams. So that's a place where in our organization, a digital business team comes in and says, we're going to set up a governance model around this. This is the path to really scaling this. And then we bring all those stakeholders to the table. So it's that technology and then that governance model that's aligned to your strategy, both digital and otherwise, we think are really two key pillars to make these things successful in a large organization.
Okay. Jeff, let me stay with you for a sec. One question people have about digital health apps is EHR integration. And I know that Banner is a Cerner customer, and that Zelf had announced a partnership to integrate with Cerner closely. So was that a factor for you? And are there ways that integration between Zelf and Cerner make Banner's life easier?
Well, yes and no. Certainly, we welcome and are enthusiastic about that relationship because that really solidifies, this integration that we want. But we were talking with Zelf long before that, and I would say we got Zelf and Cerner around the table, and I mean around the table literally, like post-COVID. Like we got in a room together and said, if we're going to implement something like Zelf, it has got to be part of a bigger platform rather than its own platform. In other words, we really see Cerner as that clinician's hub for how they're going to deliver care and manage that kind of care. So we don't want to have a digital therapeutics platform that's independent. We don't want to have a telehealth platform that's independent. We don't want to have a genomic care platform that's independent. These need to all be brought into a common workflow for those clinicians. So it was absolutely critical from day one that we thought about how Zelf does integrate into that EHR experience. And that's just one of our guiding principles is, we always look first and foremost to our customer, but we can't do it at the expense of our clinicians because otherwise you just cut the value immediately in half if it becomes difficult for clinicians to engage with those. So yeah, we're thrilled to see this investment from Cerner and Zelf and that really continued integration.
Great. So Mark, you're an informatician. So are there different use cases and different levels of patient-generated data, or how that data is going to be presented in the EHR? Does it raise some issues that you have to work through?
Yeah, I think so. And I think, first of all, I know that I'm living in the future because we're on the precipice of digital prescribing and my lights turn off automatically and turn back on with movement. So this is why we live in 2021. But to answer your question regarding use cases, I think that there are, I think that number one, technology is not like a panacea. That's the first thing. It's just another tool, and ideally, it's a multiplier, a force multiplier that enables us to get to more people and ideally, hopefully, improve healthcare and improve ease of access. Those are kind of the pillars that I see with any technology that we try and do. And certainly digital prescribing is, I think part and parcel to a successful kind of technology stack. And when we think about that, and with governance, you need that in order to effectively and appropriately kind of govern what gets on the technology stack. But when it comes to use cases, I think that there's large opportunities, certainly with existing vendor solutions that we're already using, but maybe we're not optimizing the use of, such as the WellDocs situation that I described earlier. But frankly, there are even potentially lower hanging fruit, right? So one other use case that we saw quite a rapid adoption for with this was a very simple one, which was actually just distributing, homegrown kind of information through PDFs and multimedia. Our breast oncology team over at Brigham and Women's and Dana-Farber really were able to leverage this solution in order to send out a significant amount of education that was otherwise quite cumbersome to create. So not only are there more there are different levels of kind of applications and digital kind of solutions or assets that need to be considered. But more appropriately, I think having a solution that's able to kind of enable both those spectrums, very, very integrated solutions that are discrete applications with, the dream is a single sign-on, one click, always through in my case, Mass General Brigham kind of experience, even if it's a third-party solution. And then as a clinician, being able to see that information integrated into my patient's chart without having to log in, potentially getting notified about, abnormal results or getting pinged from this application. That's the dream. But also, there's another gradient, which is much lighter, which is, what if we just automatically identify that a patient could benefit from smoking cessation? I know some colleagues at other sites are using that use case, and we just auto send an email, potentially labeled with, our system and maybe their PCP saying, hey, we think that you might really benefit from taking a look at this video and this pamphlet about smoking cessation. And by the way, we have this free course if you'd like to join. So I think that's like the gamut of opportunities. And as an informatician, there's a great saying, which is it's 20% technology and 80% people and process, and much of that work is still very much, at least in our case, the governance and the people and the process as we kind of move forward with this.
Great. Sarah, did you have anything to add about that EHR integration and kind of what levels of what amounts of data that the providers want to see from the different apps? Does it depend depending on the use case?
Yeah, I actually just wanted to pile on maybe to what Mark said about the scale opportunity, and just I could give a couple of examples of how we've thought about it within the context of Providence. And so, like the first thing I kind of described is the at the point of care, at the point where the provider and the patient are kind of face to face, and the provider using a digital platform to prescribe apps, products, services, right? That's kind of on this one-to-one basis. But to what Mark said, there's this tremendous scalability opportunity to, in an automated with really like smart rules, be able to prescribe at scale in different other services or apps without requiring an actual visit. And so, we're doing that. For instance, we're starting to look at that with respect to behavioral health and the prescription of computerized cognitive behavioral therapy for anybody who we think that might benefit from self-service sort of tools around depression and anxiety and stress and resilience management and things like that. We're also doing something similar as it relates to maternity care, as what Jeff described, at scale, excuse me, for women who, excuse me, we think would benefit from a sort of what to expect when you're expecting kind of experience through Wildflower Health. And similarly, we're doing things around advanced care planning. So really it essentially takes that like one-to-one experience and blows it up and lets you do it at scale across any use case where there's like some logic and rules that you can apply to identifying patients proactively and not having to rely on a visit to do that. So I think that level of integration into the EHR to provide that data is really powerful and tremendous in terms of like enabling broader adoption, in addition to all the governance and things and the people and the process that we've talked about. Like that's really key.
Great. Well, Sarah mentioned this earlier. I'm gonna turn this question to Jeff first, but we want everyone to weigh in if they want to. Is there a role for partnerships with payers on, say, value-based care models that include these apps? Banner's an integrated health system. Do you work with the insurance side to see if there's a model where there's a partnership?
Yes, absolutely. And, I think in terms of a traditional hard ROI, it's going to be really hard to push these forward without recognizing that a lot of that benefit really accrues to the payer. So we absolutely are looking at how we kind of triangulate around that patient in terms of the full value proposition. So we haven't done that quite. We're looking at how we extend a couple of our existing things that we have on deck to be more of a benefit covered type of solution. Certainly there's some additional modules within Baby Scripts that our own internal plan is looking at covering. As we move into this behavioral health, where we're at risk on a Medicaid plan that we administer in the state, there's a huge opportunity to show real cost savings as well as better care. So I think we absolutely have to have the payer at the table. In fact, this past year, we weren't able to do it, but we had one of our big payers reach out to us and said, we've heard about your Baby Scripts pilot. We want to pay for it for all of our members. And unfortunately, there was some certain terms around it, and it was in the middle of COVID. We couldn't act on it. But that's the kind of, I think, as we are able to demonstrate on the clinical delivery side, the real value of these and the engagement levels and the outcomes and the improvements to care, I think we're going to be able to have those conversations with our payers in a way to say, this really makes sense for you to underwrite this. We're all going to win. The other thing I think is really key to this, and I don't mean to offend any payers that are on the call, but our research shows that if you want to engage a customer in their own care, they're much more interested and apt to do that at the behest of their trusted physician than an insurance company. And so there's that opportunity to partner on this and really drive the prescription and the therapy from the clinical side and from their trusted physician. And that benefits the payer to be able to tap into that kind of engagement success that they might not get on their own.
Sarah, do you want to weigh in too on that topic?
First, I just wanted to agree with Jeff. I mean, there's nothing more powerful than the physician's proverbial pen, and so there is a much closer and their patients are much more likely to engage. Most payers, in fact, have they have digital apps that they are making available, for instance, to their patients, and they struggle with adoption partly because the strength of the relationship between the patient and the provider is really where this is facilitated. And so I think that I just agree with Jeff completely. The other piece around payers that we've been encountering is that there's the efficacy piece and then there's the effectiveness piece. And one of the things that we've in our conversations with payers, as we say, hey, there's like, you're accruing the value and we're paying for it, how do we actually make this equation work a little bit better, is that they are concerned about effectiveness in our environments, not just the efficacy of like a tool in an ideal state, right? And so we're starting some demonstration projects with them where, like in the case of behavioral health, for instance, utilizing Zelf, we're going to prescribe both sort of in an automated as well as non-automated fashion to certain payers or certain members, really like member patients within a specific payer and provider class. We're going to be prescribing digital CBT, and they're going to be, we're partnering with them to say, we'll run the program, you do the analytics to determine in this, from an effectiveness standpoint, the impact on total cost of care. And so we can actually get through this demonstration project real life data for them to then take back and say, okay, how does this actually translate into how we pay for it? What's the ROI, et cetera? And so that's where we've started with some of this work so that we can actually have a much more sort of partnership orientation with payers. And so I think, that'll be really an interesting proof point over time as to how you can build upon that from a payer provider integration standpoint. So that's one of the places where we've started.
I interviewed Dr. Brad Crotty at Freighter Health System, and he said they were making all the apps through that they made available to their patients through Zelf free to the patients so far, but he kind of had his eye on the value-based care payment arrangements in Wisconsin with payers as kind of what they were looking at for the future. Mark, you have any thoughts on that?
Yes, I think that's basically, I agree with everything that Jeff and Sarah have said. In many ways, digital prescribing and as a multiplier and as an enabler really shines in situations where there's risk or potential value generation. And I do think that there is an avenue, and as I believe Sarah mentioned this earlier, I think insurers and payers are seeing the pain points as well. So having a channel that can be trusted and also aligns with current workflows on the provider side, it all just kind of makes sense. I will say that at least our organization, where we're still a little early, we're still kind of working through kind of our initial use cases with digital prescribing. But my sense is that pathway that Dr. Crotty and team are kind of pursuing is a very valid and rich one that I hope someone will crack, and then I hope to learn more and translate.
And if I could actually add to something, as Mark was talking, this kind of spurred something for me. Another issue that we're having is that it's not sufficient to simply prescribe the app. or the service or the product or what have you. There needs to be, going back to our conversation around governance and people and process, an actual program built around this that that makes it effective. And so I think, that's the apps or whatever we prescribe digitally are not sufficient unto themselves. They are part of a broader care model or operating model, and that's what we need to work through in order to actually reap the value of it, and or to demonstrate to payers, for instance, that there is value to be had in these real life environments. And so that's just, I think that's a key part of adoption. It's not just get it out there and like they will come and all. It's not a panacea, as Mark said, right? It's one component to the broader solving the broader problem. So really, like from our perspective, like technology is the instrumentation that can allow some of these things to happen at scale, but the program needs to be built to enable that. And it can't, by the way, be the same really friction-filled, difficult to navigate offline things that you then just apply digital to, right? It actually needs to be redesigned.
Yeah.
20% technology, 80% people and process, but we're going to get there. I have faith.
I was interviewing a surgeon last week, and they colorectal surgeon, and they were deploying a patient engagement app called Twistle, and he said they had to really redo their processes so that because you're basically promising people post-surgery that you're going to respond to their concern very promptly. And if you fail at that in that initial phase, they'll drop it. They won't stay with it. So you have to make sure that your processes are in place, that you're getting back to them right away with a solution. But he said they had, they presented some interesting statistics about cutting down on ED visits, cutting down on hospital readmissions just in a couple of years. So it was interesting. Well, Mark, you run an innovation hub where digital health tools are being created, either internally or in partnership with startups. So is the Zelt platform a place where those innovations could be piloted and then rolled out potentially?
Absolutely. I think there's definitely that potential. This is actually a really great conversation we're having just regarding what digital is, what it means, and how you just can't throw an app to solve a problem, right? You have to ideally first, and we see this a lot with kind of early stage researchers, clinicians, folks that come into the iHub, and a common thing we see is, I want to make an app for XYZ. And one of the things we'll do is just kind of better understand the pain point, what the solutions are, and then kind of walk the innovator through kind of where they are in the process. But importantly, get a sense back to kind of what we've already talked about, which is that technology really isn't the panacea. It's going to be the thing that really enables, ideally, an existing process to go at like 100x or 1000x, or really move things forward and automate kind of repetitive processes. That's where I think technology can really shine. And just getting people kind of on that page is incredibly important. But certainly, with some of the work that we do at the iHub, both helping our innovators, but also creating kind of solutions for the organization and Mass General Brigham, distribution is always a thing that we think about. And I think historically, we've tried to use kind of low barrier methods for distribution, particularly when it's internal to staff solutions. We'll try and use, like web applications, because URLs are easy, they're pretty portable. And, because we have single sign-on enabled across the organization, it's a fairly painless solution to be able to kind of enable digital use cases in that way. For patients, with our patient portal and certainly things like digital prescribing, that's the opportunity to really affect and touch our patient population. And absolutely, I think that opportunity both extends to vendor solutions, but also homegrown solutions. And I think that's clearly on our roadmap, and I think probably for everyone else on this panel as well.
Here's one I'll throw out to the whole panel and see if anybody bites on this one. When it comes to prescribing these, does your organization have to vet each individual app closely? Do you have to have business associate agreements and assurances about their privacy of data? And if so, does that slow adoption? Could there be a way for an intermediary to, provide that trust certification to kind of speed up the process of adoption?
I'm happy to take a pass if that's okay. I don't want to overtake this. I'll be very quick. I think we're in a fairly early stage with kind of our work with Zelf, and I think as many healthcare organizations, I think we take privacy and security incredibly seriously. So the answer is yes. We are at this point are vetting each solution independent of Zelf, and frankly, because most of those solutions were already being used prior to our implementation of Zelf, as I mentioned earlier. I do think that moving forward, that is clearly an opportunity to try and leverage kind of a broker to help with this, whether it's through a Zelf or potentially another potential business opportunity. I think there's an opportunity there. When I think about that, though, I think again back to the 100,000 foot change management kind of thing that we would have to tackle to really make that happen. But my sense is that is where we will eventually head towards. It just may take some time. But I'd love to hear how Prav and Banner are thinking about this.
Yeah, I think at this point we are still vetting all of these individually. Now, I say that, however, with the Zelf integration, we've been able to fast track some things that make the implementation a lot faster. So if we know that these solutions are coming through the pipe that's already got Zelf and Cerner integrated, we get a fast track on some of that information security review and some of those kinds of things that would really bog us down if we were doing direct HL7 integrations on a case-by-case basis. So there's benefit at that level. I think, though, that it'll be a while before our clinical teams would just say, well, Zelf or some other housekeeping or some other group gave it the good housekeeping seal of approval, so that's the behavioral health app that we're picked. I think just, due to the unique nature of everyone's system and market and population, I think we're going to still want to vet, those solutions at that clinical level. But who knows? It could get to a point where there's some that are just so routine and they're so established and the data is there and the cost to entry is so low. You may say, hey, let's just run a pilot with this. It's already there, and it's a one-day implementation to put it out to 100 patients. Let's just see what it does.
Yeah, and I think my comments would be very consistent with what Mark and Jeff said. So I won't repeat anything, but I will say it's really like the power of that one-to-many connection, this like kind of power strip approach that Zelf provides is not to be the value cannot be overstated. That's very important, whether it be from and I would say like least of which is the integration burden that gets kind of removed from the health system from an IS standpoint. So I think, that's the power of platforms, is that's what they enable, is sort of many one-to-many kind of approach. And so I think, that's a really key step in kind of smoothing over some of the other challenges that we've talked about.
We have a question from the audience. It kind of follows on from what you just said, Sarah. It says, for a new digital product that's highly demanded by the providers, how important is a Zelf integration for pilot selection? I'm sure that'll vary from health system to health system, but
I'm sure it varies from health system to health system, but let me give you, a vocally self-critical example of where we didn't do this particularly well at Providence. We too have partnered with Twistle on surgical pathway sort of patient engagement for planned surgical procedures. And we didn't do Zelf integration, partly because there was this sort of, in our journey, this notion that, hey, what you need to do is you need to vet clinically separately every single one and make sure that, we get the right adoption and the provider buy-in and all that stuff, which is important, right? I'm not trying to gloss over how important it is, but that we wouldn't do Zelf integration until that time came. So our pilots were relatively successful, but what did we see? We saw low adoption. Why do we see low adoption? We see low adoption because it's difficult to get Twistle in the hands of our patients, and only a very small number of providers are engaged in this sort of very heavy-handed, offline, get your front desk involved, like all of the things that we do to add a ton of friction to getting Twistle in the hands of our of our patients and our providers. And so we didn't do it that way, and we are now seeing the result of that, which is that there's of the eligible surgeries, a very low percentage of them are actually engaging with Twistle. So I think it's important to create this mechanism for Xealth integration being an enabler of pilots early on. And I don't think that, like, at Providence, we haven't done that particularly well.
Jeff, do you have an idea about that?
Yeah, I would certainly encourage anybody that if you've got momentum with your physicians to try this model of care, to push that pilot forward and see what you can learn. I think I would be looking out of my other eye at something like Xealth to say, well, if this is successful and we have other clinicians that want to do this, what's our path to scalability? But I certainly think you can get out of the gates and learn a lot. We've got some going around. We discover some every day. We find out someone's doing one, and now we're trying to bring them into the fold. But they're great because you've got a really, really interested clinical team that cares deeply about a very particular issue, and they've taken initiative to go out and find out if this helps them manage that population. So I think you can, for sure. I think you just need to be looking at what's your route to the future in terms of managing these.
Mark, did you have an idea about that?
Yeah, I mean, I think like most things, it just kind of depends, right? It depends on the use case, depends on whether Xealth makes sense for implementing or not. Certainly, if this is a solution that's already done the integration with Xealth or another integration solution that adds to the calculus, and if we can save a step, we want to do that. But I think it really just depends. Also depends on the scope of the implementation. Is this a very small, limited run pilot? Do we want to turn up this whole engine to do this, or is this something that we're just going to go gangbusters on and scale? So, like most things, it depends.
Yeah. I guess I have one more question. You guys have mentioned that sometimes the pandemic kind of came in and put a stop on certain things, or because everyone's attention was focused on that. But has the pandemic also, do you think, changed the way people feel about telehealth, remote patient monitoring, and maybe this kind of digital health prescribing as part of that continuum, and maybe given this some more momentum?
Absolutely. I think it was a shot in the arm for those of us on the digital side to make our case for dollars a lot easier. When we go through our capital allocation processes, there's just, it's not just us, a lone voice in the wilderness saying, hey, we ought to be doing this. There's just a lot of customer sentiment that we can rely on saying, I want this. I think the other thing that we've really learned too, or maybe it's just been emphasized, is that safety is a new value for our customers. We've always known they want convenience. Obviously, they want really good quality clinical care, but they're looking to their health partners to be the trusted ones to guide them through these types of things in a really safe way. So that safety component of touchless environments and unnecessary public spaces, I think is really been heightened through the pandemic as well.
Anybody else?
I would add, I agree completely. And, one example, for instance, for us was we had been talking about RPM and home monitoring for many years. And last April, we stood up a COVID home monitoring program with our telehealth clinical operations team, along with Xealth and Twistle, actually stood one up in 4 days. So it just went from, 0 to 60 in a very short amount of time. The other factor around safety that I wanted to just like sort of maybe the other side of the coin as it relates to these kind of new efforts is that I think what COVID did was it reframed for us like the basis of comparison for experimenting with new things. So often, when we look at digital health, it's actually, I'll give an analogy, which is like it's like the autonomous car, right? There are millions of car accidents every year, but the second an autonomous car gets in an accident, it's like, oh, should we put the brakes on the whole thing, right? And it's that one adverse event that causes us to question this new kind of approach. So the basis of comparison is against the ideal as opposed to the current state. I think what COVID did was to say, maybe the basis of comparison shouldn't be against the ideal, but it should be against the current system. And are we improving upon the current system? And allowed us to like view safety and our tolerance for risk in a different light, which I think was very helpful for innovation. And it's not that it was irresponsible, right? It was still responsible, and we were very engaged between clinical and operating and technology teams. But we just viewed the problem slightly differently.
Okay. Mark, any last comment? Nope.
No, I agree. I mean, what would take like months to years, we were doing in like hours to days, which was wild and exhilarating. And I think the only other thing I might just add is, that kind of rocket fuel to digital health during COVID also kind of exposed some considerations that I think we would have naturally got reached in due time. But because of just the compressed timelines and what we were doing at such a fast scale, really brought these things into light. And in particular, having a digital strategy that is both inclusive, yet also not finding that balance between inclusion while also not kind of slowing down the release of digital tools for the sake of being like comprehensively inclusive has been something that we've been working on very, very thoughtfully. A lot of really, really talented folks have been trying to figure out ways to kind of balance those two pieces, and just making sure that we have advocacy for groups that might not utilize kind of these digital tools. What we've seen, even in our most successful rollouts during the pandemic and moving forward, there's always a percentage of the population where digital just is not going to work. It's just not the thing. And making sure that you account for that, and particularly when you're, like a Banner or a Prov or a MGB, in a situation where you're going to be dealing with, and probably like most of the states, patients and populations that are quite diverse with different needs, understanding that you still need to have solutions for everyone, ideally, is quite important as we kind of move forward.
Great. Well, I've really enjoyed this conversation and hearing from all three of you. I appreciate you taking the time to talk today. I'm going to turn it back over to Matt now to wrap up.
Yeah, thank you, David, and thank you, panelists. A fantastic deep dive into digital health prescribing. Okay, now we are on a ever so quick 30-minute break before our next session which will be a discussion on the digital front door. How can increasing security actually lead to less friction and better usability? So we will see everyone back here at 3:30 p.m. Eastern time. Thank you very much.